Hi, this is Brian Kim. I'm going to share with you this patient who had negative dysphotopsia with a single piece acrylic intraocular lens in a capsular bag. And so I'm going to show you how I took that lens out and I replaced it with a three-piece sulcus lens implant. Some surgeons have the impression that if the lens is inside the eye too long, that it's too late to exchange. And so I don't believe that this is the case. You have to be able to get underneath the anterior capsular rhexis edge and really very gently dissect and visco-dissect within the capsular bag the haptics. As you can see, I'm making my paracenteses incisions and then injecting intracameral lidocaine and then dispersive viscoelastic. I make my triplanar corneal incision, I make a vertical groove and then tunnel and then enter the anterior chamber. This is dispersive viscoelastic mounted on a 27 gauge needle. Some people use a variety of devices or instruments. I feel a simple hypodermic needle is sufficient. You just want to get underneath the anterior capsular rhexis edge. Usually if there's quite a bit of time that's gone by, the anterior capsular rim right there is somewhat rigid, and so the likelihood of puncturing or causing an anterior capsular tear is very, very low. And I haven't experienced that myself, so I don't think it's a big issue. After you're able to place that needle underneath the anterior capsular rhexis edge, you fill the bag with viscoelastic as much as possible, and then I'm using a cyclodialysis spatula to kind of sweep side to side to create more separation. You go in with the viscoelastic cannula, and with the cannula, you go deeper and push more viscoelastic into the capsular bag. So the key is taking your time. You want to make sure that you completely separate the capsule from the lens, not just on the anterior capsule, but into the capsular fornix, and then eventually into the posterior capsule area. And so you're just using the cannula and a cyclodialysis spatula alternating in between to really gently separate the anterior capsule 360 degrees from the lens, and then deeper pushing viscoelastic into the capsular fornix, and then eventually lifting the lens up and separating the lens from the posterior capsule. You want to go 360 degrees, very slowly, very gently, pushing that viscoelastic all the way around. If you need to use more vials, that's okay, but you really want to make sure that there's no adhesions between the lens and the capsular bag. If you try to pull the lens out while there's adhesions between the lens and the bag, then you're going to get a capsular tear. Once the lens is completely freed, you can use any instrument to try to dial the lens into the anterior chamber. In this case, I'm using a Sinskey hook. I'm grabbing the optic haptic junction and I'm lifting the lens up on the right side, and then I'm doing the same thing on the left side. You want to make sure that the haptic is still not incarcerated within the capsular fornix. Sometimes the haptic can be incarcerated in some fibrotic capsule, and if that happens, you don't want to pull and rip the zonules, and so you may have to amputate the haptic in those cases. But in this case, that did not happen. I was able to free the haptics completely, lifting the lens up into the anterior chamber. You want to make sure the bag is completely filled with viscoelastic, as well as coating the corneal endothelium. And then you want to grab the lens with the microforceps and scissors. When I grab with the microforceps, I cut a little bit, and then as I'm cutting, you'll see that it's better to re-engage and re-grab with the microforceps. So as I cut, I let go with the forceps, but because the teeth of the scissors are still holding the lens, I'm able to pull downward and access the more distal part of the lens, so I can re-grab with the microforceps and then to continue cutting. So you want to cut and then use the scissors to hold, re-grab with the forceps, and then cut, and you want to go back and forth. That's a little bit of a neat trick that I've picked up. So you're able to use the scissors to hold the lens so that you can re-grab with the forceps. So you can see I'm taking each half of the lens out. Since this is a single piece acrylic lens, it just folds very easily, and some people won't even cut the lens in half, but I think it's just safer and more gentle on the endothelium. I'm filling the eye with some cohesive viscoelastic into the ciliary sulcus on each side, and then I'm injecting a three-piece intraocular lens into the ciliary sulcus. I remove the viscoelastic with the INA tip going underneath the lens first, and then removing the viscoelastic in the anterior chamber, and then I hydrate my incisions. This patient had significant negative dysphotopsia, enough to warrant removal of the lens. Again, most patients have reduction of the negative dysphotopsia over time. Typically, I reassure patients and advise them not to have the lens exchanged for at least 6 months, because over time it does get better. But this is the occasional case where the patient is significantly debilitated by the negative dysphotopsia, and so we went ahead and did the exchange. So my points are, don't be afraid to exchange these patients. Even months or years later, the anterior capsular rim is fibrotic and strong, and so you don't have to worry about tearing it. So I use a hyperdermic needle. You have to be able to get underneath the anterior capsular excess edge in order to be able to do the exchange. So as long as you can find one place where there is anterior capsule overlap of the IOL, you'll be able to get underneath it and dissect. You just have to make sure you free up the lens from the bag completely. That's anterior capsule, capsule fornix, as well as posterior capsule. As long as you do this, you'll be able to remove the lens safely and have an intact bag, and then place the lens in the ciliary sulcus, as we did in this case. This patient noticed significant reduction in the negative dysphotopsia, and the patient was happy. I hope this was helpful to you, and thank you for your attention.